Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. How are you?
Great. 2025. Excited. New year. We're officially in and we've given all our predictions for the future of hand surgery and we've dealt with Snowmageddon in St. Louis.
Oh my God, we have dealt with Snowmageddon, and we're getting more as we speak on January 10th. I was thinking about our Future of Hand Surgery podcast, and the only thing we didn't discuss was artificial intelligence. And it really wasn't the purpose of that episode, but it's another interesting topic which we could touch on today or another time.
Yeah, we absolutely should. I know we've gotten some great emails from listeners about AI, and I think that we should probably devote an episode to it to maybe even have a guest again in terms of discussing that. What's going on in your world? I've got a meeting coming up I'm very excited about. By the time this episode drops, it'll be on the tail end of that meeting. But how about you?
Yeah, well, I can't compete with a Hawaii meeting. There's no competing with that. No, life is quiet. B school last 4 months. A lot of travel coming up, but all is well. Had a great holiday with the family. Yeah, all good.
Yeah, it's good. Somebody asked me recently about my travel coming up, and I had a hard time remembering it, which is good. So, in terms of work-related trips, I'm very happy right now that I don't have a lot coming up. We've got a big spring break trip coming up in a couple of months, but yes, it's people always ask, you say you're going to a meeting, and they say where, and they immediately judge you when you say Hawaii. But it's the American Society of Peripheral Nerve, and also concomitantly the American Association of Hand Surgery. Although I'm not really doing much for that meeting aside from a jointly programmed ICL with the ASPN.
I'm definitely judging, but all right, a little bit of a tangent. And my business school interest and all that stuff. There's a guy named Jesse Itzler who I don't know what he did to make a mint. He married a woman, I believe, named Sarah Blakely, who started the company Spanx, and I
Ah,
think
yes.
was one of the first self-made female billionaires. But occasionally I see Jesse, and I met and hung out with Jesse a bit when I did the Duke basketball camp, and that's been many years. Like
That's right. I forgot about that.
we had,
That is some grown person. I've made it, and I want to relive my childhood dreams.
yeah. And the key is, I think you have to be at least 35 to do it. I was maybe 36, but I
You
could
don't have enough
never.
money to do it until you're 35 or
Well,
36.
if you do, then that's exactly right. Anyways, talking about the travel, I have thought about, and I think you may have something like this in your office. He is like sort of marketing this year-long massive calendar where you
Yeah,
can visualize what you do.
right there.
Yeah, his is about 5 times that size.
Yeah. I
Um,
used to have a bigger one, but then somebody made me move offices, and yeah. So,
yeah, it's just interesting because I struggle, and like I think my stress level is directly proportional to my grasp of what I have going on. So occasionally I go take these deep dives into where I'm traveling, how I'm prepared, do I need flight tickets and all that stuff. And there's many techniques to decrease the stress, but just organization and visualization help.
yeah, no, I'm a big visual person. So whether it's doing a wall calendar for traveling or whether it's when I have my New Year's resolutions, like literally checking a calendar box, which I did talk about with a fellow recently, Eric Jang, about his New Year's resolutions, and I'm a big visual person. So and I think I don't know, you probably are at the point as an executive now where you are probably counting the number of days you travel. I know a lot of people who are big in the executive space will say, I'm only traveling X number of days this year and become much more selective about which opportunities they decline or accept based on how much travel they've already committed to. So yeah, no, I need to see it. Whenever a trip comes up or an invite comes in, automatically the email is to my admin saying, please put this on Outlook, please let the clinical team know, and please put it on the wall calendar. And all of that has to happen. I need to see it in a certain way. I'm old school that way. I still print out things too. So I mean, yeah.
It's so interesting because you're not the only one who prints things out. I am old and do not print stuff out. But Lindley Wall is another example. She prints everything out or handwrites.
I remember getting a manuscript back from well, I'll say from Dr. McKinnon, and I got a manuscript back from her. We were working together on a paper. It was printed. It was in red pencil, and I was like, "This is just like my childhood." Like, I used to send my papers to give my older sister, who's an amazing writer. I would give her my papers to edit, and she made me a much better writer. But it would always come back in red pen. So a little bit of PTSD, but it made me better in the end. And I actually helped rewrite a introduction for a medical student yesterday, and I wrote it out on a notepad and then just typed it up because it just the thoughts flow better for me when I have pen in hand.
That's so interesting. I think it's a this is a real to me this is a super interesting topic because it's also about like how do we absorb knowledge from a reading perspective? Like can you learn reading and highlighting on a PDF versus a printed document where you're marking it up? I actually have made myself transition to the PDF absorption model, and that's what I've done in school as well. But as I think I've mentioned before, again, I'm one of the older people in my class, and I'm one of the few people who uses an iPad and markup like that rather than looking at the printed version.
So when you go to, it's a really interesting point. When you go to a executive council meeting or whatever for the Hand Society or everything else that you do, a lot of times those agendas now are completely electronic, and they say we're not going to print them. Do you still print them, or do you just go electronic?
Oh, I haven't printed anything like that in 10 years.
Yeah.
Yeah, do you still print?
Occasionally. Sometimes it's because I forget to attach the PDF to the Outlook. It's a whole thing, but yeah, no. And I've gotten grief from the amazing hand therapist I work with in clinic, Jamie Findice. She gives me grief because every time I read an op note, because I'm like going to tell her something, I will highlight the text as I'm reading. And somehow it's like a pet peeve of hers or something, and I didn't realize I was doing it. So I'm a big highlighter. I had to restrain myself when I was in medical school the number of different highlighted sections because then the entire page was highlighted when I was reading. So
That's exactly right. I mean, there are some, and my kids obviously guided me. There are some amazing apps for the iPad, I'm sure for every possible electronic device that really allow you to mark it up like it's a printed document. So it's been great. I really like it. I've adjusted, I've adapted, and the more you mark up, I think the more interactive you are, however you do it, the better.
see that dog's getting some new tricks. I did say
Not
old
many.
dog though. So we have some really interesting cases to discuss today, centered around thumb CMC. I know I sort of surprised you with this topic, with this request, but I think it's relevant. I had some really interesting questions to ask you about it. But first, before we dive into our clinical topic, we should probably acknowledge our wonderful sponsors and friends over at PracticeLink.
Absolutely. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand. Now, one thing I want to ask the folks that are listening or watching before we dive into the case is I grew up in Florida and I'm trying to figure out how to deal with all this snow. And the question I have is, two questions just to throw out there. You don't have to answer them. I just want people to tell me what they think. Do you salt your driveway, sidewalk, etc. before the snow falls? Or do you wait until after the snow falls? And then is there utility in doing like a mid if you have snowfall and then you got to break for a couple of hours before the next wave, should you shovel before the next wave of snow falls? So those are things that I've been struggling with in the last week, trying to figure out.
Those are great questions, and I grew up in Alabama, so I'm not going to be the resource to help. This is an epic snowfall for St. Louis because for a couple of reasons. One, it's typical that 24 hours later it's 50 degrees and the snow is gone, and we have stacks of snow, which we never do, and now we're getting more snow. I don't know the answer to those questions. I don't have a snowblower. We marginally shoveled, but the reality is we're sort of just ignoring it and hoping it goes away before neighbors complain or anything. So
It was
it's
so gratifying to shovel the driveway after, I had a case on the snow day that we had was a Monday. I had a case that went, and then fortunately, and then I came out of the case and found out my clinic was canceled. So I just knocked out a bunch of stuff in the office. Had to buy a new snow shovel because I fractured my first one,
and
and
they were
learned that
available.
yeah, exactly. They were. I had at my second store. I was in luck, but I bought two just in case.
I've got a
Anyway,
whole assortment. Yes.
it's a whole
Anyways,
thing. Let's dive into our case. So, this is one that was sent in by a listener, and for obvious reasons, I'm not going to disclose who, but we appreciate you sending in a case. So, this is one in which there's a younger patient, like young by anybody's stretch of the imagination, who had a trapeziectomy and a suspension with a tightrope. I don't know if there's a way around discussing the actual name of the implant, but the pain, and it is still having pain, and this is, a number of months later. The pain is not necessarily at the trapeziectomy site, but is actually just where the button is on the second metacarpal. Um, the question is, do you, in terms of if you're going to do something surgically, would removing just a button destabilize the construct? And how would you go about that? I mean, I don't have a lot of experience with the tightrope, so I'd love to hear your thoughts, Chuck.
Yeah, so it's an interesting question. I'll start by saying I like the concept of the mini tightrope for CMC. You can use it for CMC arthritis. You can use it for instability. Sometimes it can provide enough stability to kind of solve the problem. I never use it in a primary situation, but it is my go-to of choice in a revision situation. The reason I don't use it in a primary situation is one, it can be a little technically finicky to get the path directly correct between the base of the thumb metacarpal and the base of the second metacarpal. And that can be a little tricky, not that tricky, but can be a little tricky. And you want to not just hit the second metacarpal, you sort of want to hit the second metacarpal in a way that the button that'll be on the ulnar side of the second metacarpal is not too dorsal. And
Right.
if
So it's got to be straight ulnar and not dorsal.
Right. And then you ideally even can bring some fascia over the top to prevent this problem. And so this is a problem. This is a recognized frustration with this technique. And the reality is, I am fully supportive. Knock on wood, I've not had to do this, but the person should absolutely take out the button because I think that conceptually you're looking for scar tissue like you are with an internal brace and like you are with a trapeziectomy with pinning. You're just looking for scar tissue, and usually that's sufficient.
So that's I mean, so a lot of great pearls in there, and I don't have, I think I saw one of these in residency, and then when I got here, nobody was doing it for fellowship, so I haven't really seen it. It's interesting that, and I'm aware of the literature that she described with this being an issue. I mean, you described that as your go-to technique for a revision. Does it matter what was done the first time around? Because then when I talk to patients about the difference between a suture tape, suspension, internal brace kind of thing versus an LRTI, I tell them, my backup is the other one. I don't really even put tightrope in the equation. I think I'm biased because of how I was trained. But when is this your go-to? Like,
So the benefit of using this technique, that is the mini tightrope technique, in a revision situation is simplicity. So usually when you're doing revision, no matter what the primary surgery was, you have a bunch of scar tissue which exists where the trapezium used to be. And most of the time, you're doing it because there's been proximal migration or subsidence of the thumb ray. And so the good thing is you can still distract the thumb braid distally. So you can reestablish that space. It's not like it's scarred in proximally, it's just scarred in. And so if you go in and you try to do an LRTI second, or you go in and you try to do a suture tape suspension plasty second, you got to take out all that scar tissue. You got to think a lot about the radial artery. So the beauty of this technique is you distract the thumb and you fire your mini tightrope across the thumb metacarpal to the index metacarpal, and you're done. And I have been super happy with this technique in the revision setting.
okay, well, that's really good to know. And that's actually a really good segue to our next clinical question. And before we do that, I wanted to discuss our friends over at Checkpoint. They've got on February 8th, which is coming up pretty quickly. Checkpoint is supporting the Ohio State University Upper Extremity Nerve and Tendon Surgical Skills course for fellows and practicing surgeons. Course faculty includes doctors Amy Moore, Kyle Eberlin, and Holly Power.
To learn more about this program and to register, please visit nervemaster.com. You can also find the link to register in the Upper Hand podcast episode description. That's a cue to me to put that in, Dr.
I was
D.
going to send you the email.
Please do.
Thanks,
Uh,
Becca.
Checkpoint Surgical Driving Innovation in Nerve Surgery. And I'm in all seriousness, that's going to be a great course.
Yeah, that's going to be a great course. I think that Dr. Moore's done a wonderful job, lining up the faculty. I think it's the second year in a row they're doing it, and I think it's going to be really beneficial. So, especially if you're a trainee interested in nerve, you should go check out that course.
For sure. Let me share in anticipation of our next topic around CMC. I had an interesting patient within the last month that came in. She traveled a bit of a distance and she had had surgery on one of her thumbs. She didn't know exactly what was done. It was about 18 months ago, and she was really happy. And I asked her what was done. She didn't know, but she shared a whole bunch of x-rays. So I reviewed the x-rays. It didn't look like a mini tightrope. It did not look like it definitely wasn't an FCR or an LRTI. So I was thinking it must have been a suture tape suspension plasty, although it also could have been a trapezium excision with pinning, but I didn't.
Hmm.
I asked her about pins
Who
and she
does
didn't
that
have it.
anymore?
Well, not in this country. So I said, as she said, her doctor was almost apologetic because there had been proximal migration of the thumb ray, and it looked like there was bone on bone, base of the thumb metacarpal to the scaphoid,
Hmm.
and the X-rays certainly looked that way. But she was totally pain free. She was happy. She was pain free. But it's interesting because I think she lost a little confidence in the other physician. And so she was coming for another opinion. We talked about options, and we talked about basically for me these days, there's two options. One is a standard LRTI, which I told her specifically in my mind remains the gold standard. And the second option being the suture tape suspension plasty or tightrope. I'm sorry, not tightrope, suture tape suspension plasty or internal brace. It was a great conversation, but I think LRTI still has a really important place in the treatment of thumb CMC arthritis.
I think it does too. And I talked about my bias, obviously, and how I was trained. I did a lot of LRTIs in fellowship, a lot of LRTIs, and I still, will use it in certain situations. I mean, I guess I'd love to know your remaining indications for an LRTI in 2025.
And then we're going to talk a little about technical, I hope, as
And
well.
oh, absolutely, absolutely.
Okay.
That this is just the opening salvo.
So, as you know, we shared our experience in a prospective randomized trial looking at different techniques for CMC. And the bottom line is they're about the same. There seem to be relative.
That's just Chuck flexing his level one evidence on everybody. Look at that. So
Yeah.
impressive.
Last time I ever do that kind of study. Um, the reality is, I think the experience in the hands of the surgeon matters a lot. And there certainly is some relative pros and there are relative cons to each technique. I like the LRTI. I don't do it that much anymore because I really do like the suture tape suspension plastic because it's fast. Patients are under anesthesia less time. They start therapy within a week and at 6 weeks they're out of a splint. The only catch is I am very careful not to tell patients they're going to be 100% sooner because I don't think it's a faster overall recovery. It's just a faster return to daily activities with the removable brace. So I don't push LRTI on anyone, but there are patients who come in and I go over the relative pros and cons and they choose LRTI. But I would say it's probably 5-1 suture tape versus LRTI. What about you?
When was the last time you did an LRTI outside of the RCT that you ran?
Oh, probably 6 months ago.
Okay. How many LRTIs do you think our residents and fellows have seen?
They don't see him anymore.
And so that's actually, and it's a little bit tongue in cheek, but that is one of my remaining indications is MFE, which other program fellowship directors will know, but maximizing your fellow experience, and same thing for the residents. But I think it's an important procedure to learn how to do because it does remain the gold standard, and I probably need to work a little more at indicating that in the right patient. I think that one topic of discussion, I think one thing we talked about for the RCT that you ran was, could you still do the same rehab protocol you use for your suture tape suspensions with the LRTI patients? And it was work out of Utah showing that, I think you can potentially do that.
Yeah, or close enough. I mean, Utah looked at, I think, 2 weeks versus 4 weeks of casting, or was it 4 versus 6? But they looked at a shorter cast immobilization period and demonstrated similar outcomes. So I think you probably can. But the key with the LRTI is you have to have enough of a grasp of the tendon used to support the thumb metacarpal. And you do want a little scarring before you depend completely on your suture and completely on the tendon integrity to support the thumb. That's why I like to go a little more slowly.
Yeah, no, I think that those are absolutely good points. I mean, I think that we oftentimes forget to ask why or explain why we slow down the protocol when we talk to our trainees. So it's good for you to explain that. I think this is an LRTI. First off, my remaining indications for an LRTI is if they've had one done on the other side and they really like it, they don't want anything different, which it was one of the reasons why I did one recently. And then I use it in a revision setting, or if you have the discussion about the potential options and they opt for something that's completely autologous.
Yeah, that's great. So let me, I'm a history major. Let me give a little history here. So, Burton and Pellegrini from University of Rochester first described the concept of the LRTI, which stands for ligament replacement, tendon interposition, using either half or the entire FCR. I did some as a resident, but in fellowship in Cincinnati, we did a ton of these, and everyone sort of had the same protocol, which I think is really an amazing thing where you're doing it the exact same way every time, and patients have really, really reliable, good results. And so it is a procedure we should, every hand surgeon should know how to do, even though we may not choose to make it our first option.
So I have fond and traumatic memories of LRTIs in fellowship because it is a very technical, like you said, like it's a very technically specific procedure. It's do this, do this, do this, do this, do this, should be the same way every time. And I went back when I had a couple of recent LRTIs, which I've had in the last few weeks. I hadn't done it in a long time. So I pulled up my Google Docs from my fellowship and read my fellowship notes, which were very specific and interestingly very different based on which attending I had worked with. But the one that I remember the most, and perhaps there was a little bit of Stockholm syndrome, but I wanted to review my notes from Dr. Gelberman's rotation and reviewed all of those. And I just remember how technical it was. So let's start with the technical aspects. So is in 2025 dorsal approach or Wagner approach?
Yeah, I am a big believer in the dorsal approach. I have nothing against the Wagner approach or the Wagner approach, how you say it. The
The
benefit of
Birmingham boy calls it a
the
Wagner approach.
the benefit of the dorsal approach, as I think we've talked about, is I think the chances of irritating the either superficial branch of the radial nerve or the LABC is far less. And so there's less nerve complaints when you go straight dorsal, but the Wagner approach is elegant. It gives you a bigger approach, and there's certainly nothing wrong with it.
Yeah, we talked about this in a recent episode, but I think that if you're trying to do the kind of Genie Del Signor suspension plasty that way, I think a Wagner is the way to go. It's very hard to do from a dorsal approach. But yeah, I also would dorsal. So the technical aspects of removing the trapezium, I think, are no different. Do you do anything differently in terms of other than telling your resident fellow to really protect the FCR as you're doing this?
Um, Protect the FCR, protect the radial artery. As I've said, I went through a phase where I didn't identify the radial artery. I identify the radial artery every time. I use Homans, put a Homan in the scaphotrapezial joint, and carefully lever it because you can traumatize the radial artery. And then I elevate soft tissues dorsally, volarly, obviously expose the trapezial metacarpal joint. I have done it every which way. I typically now do not try to excise the trapezium in total. Rather, I subdivide it with an osteotome and then take it out. What's your current technique?
Kind of depends on who I'm working with and how I'm feeling that day in terms of excising the trapezium. The principles are the same. I do identify the radial artery. I like the Homans. But before doing the Homans, it's for me, it's a sharp dissection with a scalpel, or depending on what the trainee prefers, they can also use the cautery to get the periosteum and the capsule off. So the dorsal part and the initial kind of as you go to the mid-axial line can be with the knife or the bovie, and then that's making sure to find the radial artery and then also dissect out the radial artery because as you come on the different sides of it, you can also encounter some branches that you need to be mindful of, as you know. And then I'll use the number nine freer, or as our partner Marty calls it, the dingman, and use the sharp end to kind of get over the edge. And then the rule is as you get volar, nothing sharp. And I'll use the McGlamry after starting the dissection with the Homan, parking the Homan, use the McGlamry to get around the bottom. And once you're around kind of the bottom, and I think that's the reason to use the McGlamry is just to avoid any risk to the FCR. And that's when we decide whether we're going to excise on block or we're going to piecemeal. I very rarely take out an osteotome. I do like the challenge to our trainees to remove on block, and then eventually we just end up taking it out piecemeal most of the time. Although I will say, current fellow Eric Jang has done a great job getting a couple out on block, and he told me that you take it out on block. So it's interesting that there perhaps has been some deviation.
That's so interesting. I'm going to try something new for our YouTube watchers. I'm going to share my screen.
Oh
from
boy.
a random site to show what a maglanomy is for those who don't know. And this site is just the first one
The
that
metatarsal
pulled up.
elevator. Yeah.
Right. It's a foot and ankle tool. It's a little bit sharp on the tip, and it can be really helpful. So I was doing a CMC with Eric on recently, and he said he is working with you, and you love the McGlamory. And I said, well, we can use the McGlamory, but we didn't use the McGlamory. I explained why. And I think the McGlamory tool is very good in experienced hands. I think it's a tough thing to take a trainee through, in my opinion, which is one of the reasons I don't use it that often.
Hey, it's fair. Absolutely. And I think the other thing I'll say is I every time, never say never, never say always, but always I will put a pin in I'll put a 62K wire in the trapezium and check on X-ray because you don't want to be that person. Takes out the wrong bone. And sometimes the anatomy can be challenging if there's, dorsal migration of the base of the metacarpal, et cetera. You just want to be sure. This surgery is a three shots on the fluoro. And that's the first shot is just making sure that we got that the right bone. And then also I'll use that if I'm doing a suture tape, I'll use that as a gauge of the bone quality, just getting a sense of how good the bone is potentially. And so and this is just for workflow, whether to open the kit or not, if we're doing a suture tape. But yeah, so then trapezium is out.
Yeah, so well, first of all, I've never used the C-arm. I just don't think it's helpful for me. Obviously, I'm not being critical in any way. Judgy maybe, but not critical. No
It's fine.
C-arm.
It's fine. It's fine. I was down the hall when I heard the call in a different institution. So
Yeah, no, I believe it. Yeah, I do think if you're not going to use a CRM, you need to be obviously 100% confident of what you're doing, which some listeners are going to be like, wait a second. You took out someone, not you, not I, took out the wrong bone or took out the distal half of the scaphoid. Yeah, it can happen. So, trapezium's out. And now for me, you identify the FCR. I would say 99% of the time, you can get a good sense of the quality of the FCR. With severe arthritis, the FCR can be affected. So you always have to be ready to pivot, whether, again, not really necessary. And then my next step is to harvest the FCR.
well, first off, how frequently and how many times has the FCR not been reasonable quality?
Incredibly rarely, once or twice in 20 years.
Okay, perfect. So then how are you going about initially, like what do you tell patients in terms of number of incisions, where the incisions are going to be, et cetera, for getting your FCR out?
Right. So longitudinal dorsal incision for the exposure for the joint in the trapeziectomy, I make one additional incision. And that additional incision, I use the width of my palm, which is about 10 centimeters. I start at the wrist crease and then at the kind of directly over the FCR proximal to my little finger. So roughly here, I make a small transverse incision. I'll just keep going. I spread after the incision, I spread down, identify the FCR. That's usually at the level where the FCR tendon is visible as it originates from muscle. I ice,
Submusculotendinous junction.
thank you. I isolate it. I 100% confirm I have the FCR by working back into the hole that is the original incision. Once I'm positive, I cut it there. What do you do?
I do it differently. So first off, yeah, I always love it when surgeons say things based on the width of their hand.
That's how I was
There was
taught.
there was a surgeon in residency who swore that the radial nerve was always the width of his hand above the lateral epicondyle. I'm like, so repeatable, so accurate. Sure, but I will make a about a 3 centimeter longitudinal incision over the FCR just proximal to the wrist crease. Identify my FCR there, do your various checks to ensure it is indeed the FCR. Same as yours, but also including making sure none of the fingers are moving, because you don't want to be that person either. And then I make I'd like to get it, in terms of transecting it, I agree with transecting at the musculotendinous junction. I will make a couple of small transverse counter incisions, to free up the FCR tendon. And then the more proximal counter incision is where I divide the FCR tendon. In the recent case, I was really because I was like, yeah, I probably didn't need this second counter incision, but and because I didn't need all the length, I just didn't ever want to run out of length on this one, and so yeah, you're paying the penalty of cutting the tendon. So I will then make sure it's completely freed through the incisions, and then divide it to approximate the musculotendinous junction, pull it into the main to the volar wrist incision, and then try to pull it through from the dorsal thumb incision. Just by freeing it up and then pulling on the FCR there. I remember Dr. Gelberman, at least in my notes, so there may be something lost in translation. He would try to at least have a separate subcutaneous tunnel, and passing an instrument from the main dorsal incision into the volar incision, and I've not found that necessary in practice.
I will say that the benefit of the Wagner incision is when you curve volarly along the wrist crease, you get a second access point to the FCR tendon. But I will strongly say that I don't think you need it. For me, one small incision, 10 centimeters proximal to the wrist crease, the width of my hand, um, cut the
Everybody go
tendon.
measure the width of your hand. I actually did that in residency. I measured the width of my hand because I kept asking, like, how is my hand compared to Dr. So-and-so? I'll say Dr. Hotchkiss. How does it compare to Dr. Hotchkiss's hand? I was like, I don't know.
Well, it's funny because I was talking about this the other day. M Michelle Carlson, Michelle Gerwin, when she wrote the paper, talked about where the radial nerve came anteriorly, and it was 10 centimeters proximal to lateral epicondyle. And this week said, in a kid, you can't count on 10 centimeters, but it's a valid point. But for me, in the OR, it works every time.
In my hands.
Yes. So you harvest the whole tendon, not a hemitendon or half a tendon. I think people who take half the tendon absolutely have to have the counter incision. If you're taking the whole tendon, which is what I do, I don't think you don't always need the counter incisions.
Why do you take the whole tendon, not half of the tendon? Because I end up taking the whole tendon, and sometimes I end up using half of the tendon.
I take it and use it. I just think it's easier and faster, and I don't think patients complain ever about the lack of the FCR.
Right. Do you think taking less tendon would potentially lead to less soreness? Because I think that is one complaint that I've at least heard historically reported about the FCR.
It could, absolutely could. Um, don't know. I just don't get complaints about it. And then maybe that's because I immobilized for 4 weeks in the cast.
Or you
Maybe
don't
that,
ask?
or I do ask.
I don't ask. All right. So we've got the FCR into the main incision, whether that's a Wagner or a dorsal approach. What now?
Yeah. So I take a 2.5 millimeter drill bit, and we have a little set. There's a 2.5, 3.5, 4.0, and 4.5. I usually
We
take a
used
two.
to have a little set at my place, and now since I didn't use it for so long, they sent it away, which was a
Oh
very
no.
painful point of contention, which I will bring up next time I do an FCR at that or a LRTI at that place.
Yeah. So basically, you want to be in the plane of the thumbnail. You want to drill a couple of centimeters proximal to the base of the thumb metacarpal. I drill straight in, and then
Dorsal to volar.
dorsal to volar, and once I get into the medullary canal, I pull back, drop my hand, and I try to exit at the volar articular surface of the metacarpal. And once you do your first drill bit, you quickly do a second and third drill bit. 4.0 is almost always sufficiently big enough to pass your tendon.
So you talked about the McGlamory and how it's hard to, have somebody else do it through somebody else's hands. I find that to be really hard. The initial dorsal volar drop and so it's like, yeah, we could do it. They can do it, but me trusting them to do it without having done that case a lot. So I make two separate drills. I do two separate passes, dorsal to volar, and then through the articular surface to, just to open the medullary canal. And do you go to a 4.0 every time?
Yeah, I mean, if I'm using the whole tendon, I go to 4.0. And I guess if someone was really small, as in metacarpal width, I'd be a little careful. But no, I do. And I think the other technical pearl is that drill hole cannot be directly adjacent to the base of the metacarpal because you can break through
Right.
that bone. So you have to
Well,
be at
that was my
least
next
two.
question is how do
Okay.
you ensure that your tunnel is big enough for when you're drilling and moving up in those drill sizes, and then also when you're passing a tendon, it may be a little tight.
Yeah, I wish I could say exact measurement, but I think if you're 2 or 3 centimeters
I guess
proximal where
the width of your pinky finger.
maybe that's it. I'll look next time. Yeah, I think you have to be careful, because otherwise, then you got a more challenging issue if you break through the bone, which can happen, but knock on wood, I don't recall it happening.
Right, right, yeah. So, you're using the whole tendon. How do you pass the tendon through the tunnel, and which
To
direction do you pass it in?
Right. So to me, this is the futziest part of the procedure because I want to not open things that we don't really need. So trying to save money and not waste too much time. So you know that your FCR tendon is attaching to the volar base of the second metacarpal, and the whole concept of the procedure is you bring the tendon from deep exiting out the dorsal aspect of your thumb metacarpal. So now you've linked your thumb metacarpal to its deep second metacarpal insertion. And how you get it through, I usually have a whip stitch in the cut end of the FCR long enough that I can sort of pull it through and hopefully wiggle it through without too much difficulty. I don't know of a simplistic approach. I'd love to hear a pearl from you, but that's the futziest part of the procedure.
Yeah, I just opened a Houston suture passer because it's just easier. And I get it. I get what you're saying in terms of cost, but also time in the OR. So the whip stitch, I think, is super helpful. And then I use the whip stitch and kind of tubularize the end of the tendon. And I've probably at that point already gotten rid of the muscular, whatever muscular attachments are there.
Yeah,
Whip stitch it, and then pass the whip stitch through with the so I passed the Houston suture passer. You could honestly just use like a Vicryl and loop it around, or whatever
that's what I
suture that
do.
you have, and
Yep.
loop it around and put the loop through from dorsal, it exiting the articular surface, pass your other stitch, or use that passing stitch to bring the tendon from articular surface out dorsally. Um, and then use a smooth, a non-tooth forcep to help wiggle that through. A little irrigation, little prayer, make sure the tunnel's big enough.
Yeah, all true, all true. And then from there, you now have your tendon exiting dorsally. And while I'm distracting the thumb, I use a 2-O to either grab the tendon itself as deep as possible or some volar capsule. You don't want to take too huge of a bite. Um, and then I suture tendon to tendon as deep as possible I can in the wound. That can be a little tricky as well, but one or two sutures there anchor the thumb in a distracted position.
Do you loop your tendon at all?
I do not. Well, I'm not sure if I know what you mean by loop, but first I suture tendon to tendon or tendon to capsule, and then I do my favorite suture of all, the dolphin stitch.
I hate
You
that
know,
stitch. The PTSD from the dolphin stitch and fellowship with you and Gelberman. Oh man.
no, oh, it's great. So, for those who aren't familiar with the dolphin stitch, let me
I
describe
hate
it.
it so much. It is awful.
It's
It's so
beautiful.
unnecessary.
So to do a dolphin stitch and appreciate its magnificence, when you
This
suture
is like
the
this is really like hand surgeon like
yeah,
nerdiness right here, the dolphin stitch.
it's a way to accomplish an anchovy or a balling up of a tendon and put it into the space where the trapezium used to be. And so basically usually in this case, I put two stitches in. So the first stitch is done, cut short, and that's tendon to tendon. And then I put another deep stitch in, tendon to tendon, and I leave the needle attached to the long end of the suture. And then essentially I hold the tendon up and I kind of whip in and out exactly like a
The
dolphin
dolphin, for
jumping
those
in the
watching.
waves. And then at the end, you have your suture and you have your tendon, and you can just scrunch your tendon down into the wound, and you have a beautiful anchovy. And then you can close your capsule and get out of Dodge.
So I was going to ask you, do you use a suture anchor in this case? It sounds like you don't if you're minimizing cost.
Oh my God. Um, yes, I do not because I clearly am more cost conscious than you. Even though I'm not sure you use an anchor. I know our partners use anchors.
I use an anchor because that's how I was, at least the procedure I remember the most, whether it was embellished in my, and burned in my brain for so many reasons. I use an anchor and then I accomplish what you're doing with the dolphin stitch, with one of the sutures coming out of that anchor and just cinch it down.
Wait, be clear. Where are you putting your anchor?
So the anchor is at the trapezoid.
Okay.
So it's the cheapest anchor in the set. It's an old anchor. I don't even realize. I'm surprised they still make it, to be honest with you. It's got a 2-0 ethibond or suture in there, and I use one of the needles to. I will physically roll the tendon up with the tooth less forcep inside of it, and then have somebody pass the suture through a couple of times, and then remove the forceps, and then you just cinch it down with your finger because you've got your other part of the suture coming out of the anchor as your post.
Yeah, that's great. So,
An
my
expensive way to do an LRTI apparently with a Houston suture passer and an anchor.
and the CR. So my procedure, the pack. And
You don't take a
this
CRM at the end? Nothing to confirm? That's it?
confirm what?
That you did what you're supposed to do. That you've got suspension without anybody holding the thumb.
Nope. I can see that and feel that and be confident in that. Oh my God. If someone from Blue Cross Blue Shield is listening, there's the Gold Farb technique, which is about $120, and there's the D technique coming in at
No, it is not.
$1,577.
I will show you the receipts from our logs. At least what the hospital charges for the cheapest suture anchor in the set.
Yeah.
And then question for you, how often are you checking x-rays after this? Like in the office?
Yeah, that's fair. I used to get one at 6 weeks and get one at 1 year when I made everyone come back at 1 year. I don't get any x-rays after. If there's a concern about painful impingement, I will get a mini C-arm or a standard x-ray, but I don't routinely x-ray. Do you?
Uh, I try not to for the same reasons. But it will obviously very low threshold to get one if there is a concern, aside from the routine post-operative discomfort. And if they do as expected in terms of normal trajectory of recovery, then no x-rays.
Yes, it's funny. When I was a younger man, I was involved with the AAOS, the Academy's CPG for CMC, so clinical practice guideline for the CMC joint. And we were discussing kind of what needed to be included in the clinical practice guideline, and the discussion of x-rays came up. At the time, I was adamant about at least getting a couple x-rays while I followed the patients over the years preoperatively, and it became clear that the more experienced people in the room barely got x-rays pre-op. You don't, you know the diagnosis, you're treating the diagnosis. I do get one x-ray pre-op. I don't think it's necessary, but just the whole need for x-rays to assess or confirm just seems less important to me over time.
Yeah, so I'll get an X-ray if it's coming to surgery. I'll say it's for preoperative planning. I will do it when they're on the way out the door, and I will do it in the formal X-ray system so that if any insurer questions it, it is there for them to see, and they don't have to dig into my C-arms or into my note to find it.
Yeah, that's fair. It's probably smart. It's probably smart. So again, LRTI is a gold standard. I strongly feel it maintains its position there. It's a great operation. Um, I think a lot of people still do it. Maybe a study down the road could be looking at some large databases to understand, but it's a
No
good
more
operation.
studies on LRTIs, please. I think that was from you. So yeah, we can't believe we talked about 30 minutes about LRTIs, but would love to hear how listeners do it. Send us a note, handpodcast@gmail.com, or leave it in a review and let us know.
Have a great day.
All right, you too.